patients with a first degree relative to rheumatoid arthritis are more likely to have them, okay, to have it themselves. And gender, gender, which is female, okay. So when you say gender, you need to specify it is female, okay, that is more likely to have RA than men. Previous infection should be included as well, previous infection. Okay, so the onset of RA can occur after an infection. Okay, then clinical features. Clinical features, the initial symptoms of RA are vague. They can include fatigue, malaise, joint pain, swelling of joints, and stiffness. Patients will complain of joint pain and loss of function in the affected joints. Radiographs may show erosion of the joint and a loss of joint space. Okay, so additional information. According to American Rheumatism Association, okay, they have a criteria. Okay, so the criteria state that the patient should have 4 or more of the following criteria to be diagnosed with RA. So the criteria include morning stiffness, lasting longer than 1 hour for a period of more than 6 weeks. Okay, then arthritis of at least 3 joints. Okay, yeah, is there under CPG? Arthritis of hand joints lasting longer than 6 weeks. Symmetrical arthritis of at least one area for longer than 6 weeks. Rheumatoid nodules as observed by a physician. Serum rheumatoid factor as assessed by a method positive in less than 5% of control subjects, and radiographic changes, okay, on the frame of wrist and hand. So I think you can find all these from your CPG as well. Okay, then what investigation? Okay, what investigation are performed to help with a confirmed diagnosis. Okay, so diagnosis can be made by assessing the presenting sign and symptom. Then the biochemical investigation are performed and useful in confirming the diagnosis. The tests carried out include erythrocyte sedimentation rate, ESR, okay, is included here. C-reactive protein, okay, plasma viscosity, liver function test, full blood count, urea electrolytes, and urinalysis. Patient will also be tested for the presence of rheumatoid factor, okay, and anti-nuclear antibodies. These tests are not specific to rheumatoid arthritis, but they may help with diagnosis and management of the condition. Okay, so I think group 2 has included most of the thing and some being covered by group 1 as well. Okay, good. Then question 2. Okay, question 2 is the major treatment for rheumatoid arthritis include NSAIDs and DMARDs. Okay, so the major treatments for rheumatoid arthritis include NSAIDs and DMARDs, as we mentioned. So NSAIDs stand for non-steroidal anti-inflammatory drug. DMARD is disease-modifying anti-rheumatic drug. So very straightforward, it is anti-rheumatic. Okay, okay. So describe the different types of DMARD. DMARD is categorized as conventional. Okay, DMARD is a class of medication that is being used to treat inflammatory condition. Okay, so they work by slowing down the progression of the disease. So with the aim to reduce pain and inflammation. Okay, so it is divided into conventional, all right, is there? Biologic, targeted as well, and targeted. conventional, okay, and targeted. So conventional is older, oral medication. So MTX is very, very commonly being used. MTX, okay, methotrexate, okay, first line, sulfasalazine also, okay, hydroxychloroquine also, so being commonly used here. Then move on to biologic, more recent therapies that target specific parts of the immune system, and often they use proteins produced in the lab. Okay, so this type of drug is gaining more and more popularity by a lot of people are starting using it right now. So targeted, cannot see your targeted. Okay, it's here. Targeted synthetic DMARDs also it specifically targets certain molecules involved in the inflammation. Okay, so most of the time they started with conventional. Biologic is also quite commonly used, then targeted. Side effect can be side effect of sulfasalazine, okay, include nausea, vomiting, diarrhea, headache, rashes, loss of appetite, and raised temperature. Okay, are the most common side effects. Okay, then for all this is potentially fatal leukopenia, neutropenia, agranulocytosis, anemia, thrombocytopenia may occur, but it is rarely. Then hepatitis is also being reported, but rarely. Okay. Then we move on to Mrs. Anna mentions that she has to go to her nurse for some blood tests. Then why she needs to perform those tests, right? Okay, so describe. Okay, here. Okay, the question is how often should the above test be performed? So close monitoring of full blood count and liver function tests is essential initially, and then monthly intervals for at least first 3 months of treatment. Then renal function tests may be performed periodically as recommended. Okay, so but why this test? The side effects of sulfasalazine include blood dyscrasias, which usually occur in the first 3 to 6 months of treatment. Okay, so the full blood count should be checked regularly so that the hematological abnormalities can be identified at an early stage. And there have been reports of hepatitis and renal dysfunction in patients taking sulfasalazine. So therefore, liver function tests and renal function tests should be performed at regular interval as well. Okay. Then Mrs. Anna tells you since she has started taking new medication, experiencing stomach discomfort about half an hour after she has taken her tablet. What do you think is the cause? Okay, so as the symptom initially appear to be related to her medication, she may be experiencing gastric irritation as the result of her diclofenac. Okay, diclofenac. Or she may be suffering from nausea due to sulfasalazine. Okay, the gastric may be due to the diclofenac, but the nausea can be due to sulfasalazine. So can ask her whether she is suffering from any alarming symptoms such as GI bleeding, unintentional weight loss, difficulty swallowing, abdominal swelling, or persistent vomiting. If she experiences any kind of this, she should be referred to GP urgently. Okay, then what suggestion could you offer to help? With further questioning, it may be possible to clarify the symptoms and to ascertain whether one of these drugs is likely to cause the problem. You should check with Mrs. Anna is whether she's taking the diclofenac with food, okay, whether she takes with food so that it can reduce the risk of gastric irritation. So if you decide that the problem is likely to be dyspepsia, and most likely an antacid may help. In this case, however, antacid could not be taken at the same time as either sulfasalazine or diclofenac because both are entry-coated tablet and the presence of an antacid may lead to premature dissolution of the coating due to the presence of an alkaline pH. So therefore, use of antacid could not be suitable suggestion. So if this is a suspected adverse drug reaction, then we may need to suggest the patients go back to the GP to discuss this issue with them. And what are the alternatives? Okay, so if the doctor decides that the cause of stomach upset may be due to the NSAID, then normally we need to stop NSAID. However, in this case might not be possible due to her concurrent medical history of rheumatoid arthritis. So, but doctor may decide to stop NSAID and see how she manages without diclofenac and may consider adding a PPI if necessary, okay, to manage the incidence of NSAID-induced dyspepsia. Okay, if it is felt that the problem is related to the sulfasalazine and the nausea does not abate, doctor may try the alternative. Okay, so, but currently she is only on a low dose, so it will not really possible to reduce the dose anymore and still maintain the efficacy. So another option is to switch to another one if it is really bothering her. Okay, 4 months later, she returned and she has not had much benefit, okay, despite the titration of the dose. So what is the goal of therapy? Okay, the goal are to reduce the symptoms, okay, of disease, slow down the progression, and to limit the amount of joint deformation while improving the patient's quality of life. Okay, so this is our goal. Okay, the alternative when the drug has been titrated to the maximum dose that can be tolerated and the level of disease control is still unacceptable, therapy may be switched on to an alternative agent or another drug may be added in. Other treatments available for managing rheumatoid arthritis include when a drug has been titrated to the maximum dose that can be tolerated and the level is so it can be given MTX, okay, gold injection, and other drugs that is available lah. So most probably MTX is the next one to coming up. Okay, so yeah, I think that's all. Okay, if you think there is any additional information that you want to enter it into the Padlet, you can do so. But I see if combine both groups that answering the same question, I think most of the main points and main keywords has been covered. So you can save this sheet as a PDF, I think, so to keep it as your own references. Okay. All right. Okay, any questions? Any questions? We need to move on to burn.
Doctor, I have a question. For the stomach upset, right, if it's not specified in the question, so do we assume that it's due to sulfasalazine or the diclofenac?
Okay, if not, then we will start with burn injuries first. Then we can come back and talk about it later. So burn injuries. So okay, burn is a little bit different. You need to know the classifications of burn. Okay, explain the factors involved in the discuss the pharmacological and non-pharmacological treatment, evaluate the components of patient's history, physical examination, and investigation to determine appropriate management for burns and state the appropriate monitoring parameter. Monitoring parameter is quite important for patients with burn, experiencing burn, because it is a long-term battle. It takes a while for them to fully recover. Okay, so percentage of total body surface is being used to determine the level of burn. So should determine the total body surface area affected by burn using formula derived from the rule of nines and Burkow formula or Lambrowder chart. Okay, this rule of palms can be used to measure the extent of small or scattered burns. Patient's hand, including fingers, are equal to 1% of total body surface area, TBSA. Okay, so burn classification of severity, visual assessment should be made to determine the severity of the injury. Okay, visual assessment. The thickness of burn, how many layers of skins, as well as the amount of other tissues damaged, is used to classify the degree of the burn. So the severity and the degree. Okay, rule of nines used to determine the total percentage of burn area for each major section of the body. Rule cannot be used in pediatric burns. Okay, rule of nines is being used in normal adult, but cannot be used in pediatric burns. Lambrowder chart, one of the most accurate method, estimate not only the size of the burn area, but also the burn degree in both adults and pediatric burn patients, and it is widely used. Okay, classification, it is divided into the following degrees. First degree, burn refers to redness and pain of the affected skin. Minor epithelial damage occurs without formation of blister. So typically occurs with sunburn. Okay, this is first degree burn. Second degree burn, you have superficial second degree burn and deep second degree burn. Okay, for superficial, it is superficial partial thickness burn. Complete, it involves complete epithelial damage and only papillary dermal damage occurs. This degree leaves no neurovascular damage. No neurovascular damage. It causes pain, bleeds, and presence with blister. Okay, so the repair occurs within 14 days, mostly leave no scars after healing. Okay, sometimes discoloration remains. But if you move on to deep partial thickness burn, which is deep second degree burn, it involves complete epithelial damage and the damage of reticular dermis are present. Blister can be present but are bigger than superficial. Healing can occur but takes longer than 14 days. Third degree is full thickness burn. It involves subcutaneous tissues and the skin appear white and or watery with thrombosed vessel. Fourth degree can be used when burn involves the underlying fascia, muscles, and even bones. Okay, first, second superficial, second deep, third, and fourth degree burns. So this is rule of 9. So every single area, we use 9%. Okay. So for example, look at this chart. Okay. So the front and the back. Okay. So this is a front, this is a back. So front 4.5 and this area 9, 9, 4.5 each limb and 9, 9. So if a person sustain burn of chest, abdomen, and right arm, okay, chest here 9%, abdomen 9%, okay, right arm you have front and back, okay, front 9%, front 4.5, back 4.5, then the total is 27%. Okay, so and it is for infant. Okay, the area is bigger. Okay, Palmer method, another method is we use patient's palm. Each palm is 1%. Okay, this is rule of 9. Okay, Wallace rule of 9. So this is head and neck 9%. Trunk 18. Remember upper part 9, lower part, abdomen 9. So 18, front and back. Then the arm is 9, front and back each. Okay, leg is 9 and 9, front and back, 9 and 9. So 18 each. And genitalia and periodontal is 1%. Okay, so we use this Lund and Browder chart for pediatrics. Okay, 0 to 15 years old. Okay, same, we use percentage. Okay, this is modified version. So this is adult. Okay, and this is child, and this is infant. Okay, modified. So the severity of burn injury, a combination of burn mechanism, burn depth, extent, and anatomic location determine the overall severity of the burn injury. It will provide general guidance for the preferred disposition and care for this patient. So if it is minor or mild burn, so it can be treated in physician office or emergency department as outpatient. If it is moderate, require admission but not a burn center. Okay, but if it is severe, then can need to refer and treated in a burn center or in a designated burn as a. Okay, so most importantly, that we need to do after a patient experience a burn injury is fluid resuscitation. Okay, fluid aims to prevent burn shock by giving adequate fluid without overloading the vascular system and causing excessive edema. So we need to come to a balance where we need to give adequate fluid to prevent shock, yet it cannot cause edema. Okay, and we want to maintain circulatory volume in the face of ulcers due to the burn, and this is essential for cardiac output, renal perfusion, and tissue perfusion. It provides metabolic water, it maintains tissue perfusion to the zone of stasis and prevent the burn from deepening. Okay, so this is the aim for fluid resuscitation, and this is the main management that the medical team, the healthcare team need to do. Okay, because of this aim, when we successfully resuscitate the patient using fluid, then it will prevent a lot of complications. Okay, so the criteria is when the patient experiences burn of more than 15% of surface body area in adult and over 10% in children. Okay, so this group of people, they warrant a formal resuscitation. Okay, Putler formula is also being Putler formula is used to calculate how much to give. Okay, so let's watch this video.
Today we're going to go over the Parkland formula for burns. We're also going to go through an example so you can practice. The Parkland formula is good to know when caring for burn patients, and it commonly shows up on medical and nursing exams. You can find the notes, lecture, and study guide for the video on the website linked down below. All of the videos come with notes and written lectures, so make sure to hit that subscribe button to not miss out on those. Let's look at the formula first, and then we'll go over an example at the end. The Parkland formula is used to calculate the initial fluid requirements in burn patients. The Parkland formula for an adult is 4 mLs times the body weight in kilograms times the total body surface area percentage affected by the burn. This will give you the estimated fluids the patient should receive in the first 24 hours after injury. Half of that total volume should be given in the first 8 hours, and the other half should be given over the next 16 hours. It's important to remember the first 8 hours begins from the time of the burn injury and not from the time of presentation or when you made the calculation. This means if someone presents to a hospital 2 hours after a burn, they should receive the first half of their fluids within 6 hours instead of 8 hours. So the first half of their fluids may need to be administered at a faster rate due to their delayed presentation. We can see from the formula that there are 3 variables to look at. Remember, this equation is for adults, and we're going to look at the formulas for pediatrics later in the video. First, we have the 4 mLs, which is a constant. The way I like to remember 4 mLs is to use the word 4 in formula. Next, we have the patient's body weight in kilograms, which is also easy to calculate. Finally, we have the total body surface area percentage involved by the burn. This helps determine the extent of the burn injury. Only areas affected by partial thickness and full thickness burns, which are second-degree burns and higher, are counted toward the total body surface area calculation. Superficial or first-degree burns are not included in the calculation. Determining the total body surface area percentage will require calculating, and there are a few different methods for doing this, so let's take a look at them. One of the more common methods for calculating the total body surface area is the rule of nines. We talked about the rule of nines in the previous video, so make sure to check that out if you want to learn a simple way to calculate total body surface area. Basically, the rule of nines provides a body surface area percentage for different body parts, as you can see in the table and diagram. This can then be used in burn patients as a way to calculate the total body surface area involved. We're going to look at an example at the end, and this will help you see how it works. But if you need a quick refresher on the rule of nines, then make sure to watch the previous video on it. It'll be linked down below in the description. In addition to the rule of nines, there are a couple other methods you can use to calculate the total body surface area involved by a burn. So the first method was the rule of nines, as we just mentioned. The problem with that, as you might remember from the previous video on the rule of nines, is that the rule of nines is most accurate in non-obese adults, and it can be less accurate in children. Pediatric patients have disproportionately larger heads and shorter legs, which can make the rule of nines less accurate, as you can see in the diagram and table. This table and diagram will give you approximate percentages for infants and young children. These numbers will change in older pediatric patients. You can see the head is disproportionately larger at 21% instead of 9%, and the legs are disproportionately smaller at 13.5% each instead of 18% each. This is where the Lund and Browder chart comes into play. The Lund and Browder chart takes into account variations in body shape with age, and this can be used in both adults and children to calculate total body surface area. You can see in the table how it takes into account the size of the head and legs based on age. The diagram shows you the constant percentages of the other body parts. So you can see how the Lund and Browder chart can potentially provide a more accurate representation of the extent of the burn, especially in children. The downside compared to the rule of nines is it's tougher to remember these numbers and less efficient. Another method is the hand or palmar method. This method states the patient's hand, including their digits, is approximately 0.8 to 1% body surface area, and the patient's palm, not including their digits, is about 0.5% body surface area. Be careful, as you might see some literature simplifying it and stating the palm alone is about 1% body surface area. This has recently been shown to be a potential overestimation, and that the palm is more accurately about 0.5% body surface area. The hand or palmar method can be used in smaller burns, but remember, you're using the size of the patient's own hand and not your own hand to approximate the total body surface area. Now that the total body surface area has been calculated, we can figure out the total volume of fluids to be given in the first 24 hours after injury. Early fluid resuscitation is important, especially in severe burn patients. In addition to causing local damage to the skin and tissue, severe burns can generate a systemic inflammatory response, which can affect the entire body. During the inflammatory response, the capillaries can become more permeable, which means intravascular fluid can leak into the interstitial space. In other words, fluid within blood vessels can leak out into spaces outside the vasculature where it doesn't belong. The capillary leak can result in large fluid shifts from the intravascular to the interstitial space, which can cause intravascular volume depletion and edema. The intravascular hypovolemia or volume depletion from fluid shifts can lead to decreased tissue perfusion. The body will try to increase vascular resistance by constricting blood vessels in order to maintain tissue perfusion. The increased vascular resistance mixed with worsening hypovolemia can lead to worsening tissue perfusion, known as burn shock. Not to mention, cardiac output can also decrease from the hypovolemia. Hypovolemia can decrease venous return to the heart, which can decrease stroke volume, which can decrease cardiac output. So if you remember the different types of shock, we have a combination of distributive shock from the capillary leak, hypovolemic shock from the fluid shifts and intravascular fluid depletion, and cardiogenic shock from the decreased cardiac output. The way to treat this is with aggressive fluid resuscitation with the goal to maintain tissue perfusion and prevent end organ damage. Therefore, fluids play an important role in the management of circulation in severe burn patients, and this helps decrease morbidity and mortality. So hopefully you can see now why fluids are so important and why there are formulas and protocols to calculate fluid requirements, such as the Parkland formula. The Parkland formula is one of the most well-known and widely used formulas to calculate initial fluid requirements in severe burn patients. Again, the Parkland formula for an adult is 4 mLs times the body weight in kilograms times the total body surface area percentage affected by the burn. This will give you the recommended amount of crystalloid fluids to be given over the first 24 hours after injury. The first half of the volume is given in the first 8 hours after the burn, and the second half is given over the next 16 hours. The formula is used for partial thickness and full thickness burns that are typically involving more than 20% total body surface area in adults and greater than 10% total body surface area in children or the elderly. Burns involving a total body surface area less than that typically don't cause massive fluid shifts, and the patient can usually tolerate fluids by mouth. But that's not to say the patient still won't need IV fluids, and the Parkland formula still may need to be used. The Parkland formula can also be used in those with smaller burns but have injuries to the mouth or inhalation injuries that would prevent them from tolerating fluids by mouth. Those with heart failure, kidney disease, or other comorbidities that may affect fluid resuscitation should have their volume status closely monitored. While the Parkland formula is the most widely used, there are other formulas out there that can help you calculate the recommended fluid volumes as well. We're not going to go into detail on these because the Parkland formula is the most well-known, and it's commonly what shows up on medical and board exams. But this is just to make you aware that other formulas exist, and depending on where you're from, different parts of the world may have different institutional protocols. Now that we know how to calculate fluids for adults, let's look at the formula for children. The formula is the same with the exception of 3 mLs instead of 4 mLs. So the formula is 3 mLs times the body weight in kilograms times the total body surface area percentage. Children should also receive maintenance fluids in addition to their calculated fluid requirements. The simple way to calculate maintenance fluids in pediatric patients is using the 4-2-1 rule. The rule states to give 4 mLs per kilogram per hour of fluids for the first 10 kilograms of weight, 2 mLs per kilogram per hour for the next 10 kilograms of weight, and 1 mL per kilogram per hour for each kilogram of weight after that. Other formulas for children besides the Parkland formula include the Schreiner-Cincinnati and the Galveston formulas. Again, these formulas are not the main focus of this video, but make sure to know what your institution uses or recommends. Let's look at an example so we can see how the Parkland formula works. The patient weighs 80 kilograms and has partial thickness burns involving the entire anterior trunk and the entire anterior right arm. Hit pause in the video and figure out the recommended fluids this patient should receive in the first 24 hours using the Parkland formula. Also figure out how much fluid should be given in the first 8 hours and over the next 16 hours. First, we have to calculate the total body surface area, and we're going to use the rule of nines to do that. We know the anterior trunk has a total body surface area of 18%. Next, we have the burn involving the entire anterior right arm. We know the entire right arm has a body surface area of 9%. Since the burn only involves the anterior aspect, then it's 4.5%. So this patient with partial thickness burns to the anterior trunk and anterior right arm has a total body surface area of 22.5%. Since this burn involves more than 20% total body surface area of partial thickness burns, we can use the Parkland formula. We know the patient weighs 80 kilograms and has a total body surface area percentage of 22.5. So we will multiply 4 mLs by 80 by 22.5. This will give us 7,200 mLs of fluid recommended within the first 24 hours. Remember, half of that, or 3,600, will be given over the first 8 hours, and the other half, or 3,600, will be given over the next 16 hours. Just a few points to wrap up the Parkland formula. First, it's important to remember these formulas are guidelines and they're not hard and fast rules. The Parkland formula may underestimate fluid requirements in some cases, especially inhalation injuries, electrical burns, full thickness burns, and those who have delayed resuscitation. The Parkland formula may also overestimate fluid requirements in other cases. Underfluid resuscitation can lead to hypotension, poor tissue perfusion, acute kidney injury, end organ damage, among others. Over-resuscitation can lead to compartment syndromes, acute respiratory distress syndrome, or ARDS, among others. Therefore, you'll need to use your clinical judgment and monitor the patient's fluid status on a case-by-case basis. For example, you can monitor hourly urine output through a Foley catheter, as well as the patient's vital signs, respiratory status, and mental status, to name a few ways. After 24 hours of fluid resuscitation, the Parkland formula, as well as other formulas, will provide you with recommendations for the next 24 hours. Hopefully, this gave you a better understanding of burn management and fluid resuscitation. If you
Okay. All right, so I think it gives you a very clear explanation on what is Parkman's formula, and it is really widely used. So I will not repeat this. So fluid management, how to calculate it, how much fluid to use, we use Parkman formula. So this is also why the total body surface area is important for us to know how to calculate it, because we need to include that in the formula. Okay, so this guideline, okay, for first 24 hours is approximately 4 ml per kg, okay, per percentage of burn of TBSA. Okay, half given during the first 8 hours and the remaining being given for the next 16 hours. So it covers 24 hours. Okay, so this is the formula. Okay, so the endpoint, we have our urine output, just like I mentioned, to monitor it clinically as well. So the urine output will be monitored. Okay, so Parkman's formula again, only remember just now he mentioned a few times as well, only apply in second and third degree burns. Okay, so the formula is the same. Then after fluid resuscitation management using fluid, okay, the next set of priorities include pain control, thromboprophylaxis, early burn wound excision, and closure with an autograft or temporary coverage with an allograft, nutritional support, control of hypermetabolism, and prevention of infection. All these are the next sets of priority for burn injury management. So pharmacological approach, nothing much we can do but to manage the patient need to manage their pain. So analgesics comes in, opioid analgesic, non-opioid, or can be given. Okay, then the skin, for the skin, emollients and skin protectives, lipid content lotions and cream. Then the surgical dressing, we do dressing for them. Okay, dressing that can absorb drainage, increase healing time, decrease pain, help to control bacterial growth in burns. So we have those kind of patches that comes with it's like a net, okay, comes with antibacterial. Then normally we will use that kind of patch on the burn area. It helps to prevent bacterial growth and at the same time absorb the drainage. Okay, burn wounds heals the best in moist environment, so it is normally a closed dressing. A biological dressing, for example, allogenic amnion, use amniotic fetal membranes as wound dressing. Synthetic dressing, we have hydrocolloid dressing, collagen silicone coated nylon threads. Okay, then we have skin antiseptic, just a common one, povidone iodine, chlorhexidine, okay, prevent bacterial growth. And we have topical antibiotic, okay, effective against most burn pathogen. Okay, so prophylactic parenteral antibiotics are not indicated in the initial management of burn wound. Sulfonamides, okay, it is very as topical antibiotic for burn wound, okay, but it is not to be used for infant less than 2 months old, and the property of bacteriostatic and broad spectrum antibiotic will be helpful. Vaccine, okay, tetanus, recommended for patients more than 1 degree burn. No pharmacological approach. The initial therapy will be the wash burn skin with cool running water for 20 minutes. Okay, this is the common and the normal advices that we have to learn for home care. Okay, make sure to remove any debris, clothing, jewelry from the affected area. Keep the patient warm to avoid hypothermia. Wrap the patient in clean sheets. Okay, with blister, leave small blister intact with partial thickness burn. Remove thin wall of large blisters if it is more than 6 mm, especially near joint and those more likely to rupture spontaneously. Removing the extra wall will allow direct application of moist, wet dressings and the affected area. Maintenance treatment, leave small blister intact, remove thin wall, especially near joint, and remove extra. So this is for maintenance as well. Whenever it comes, then we have to maintain it using this way. Then wound care and skin grafts. Monitoring, it was mentioned in the video just now as well. We monitor the urine output, vital signs, okay, the hematocrit, fluid blood count, arterial blood gas, chest X-ray, ECG, and CV if necessary for the rest. This is a case. It is not a complicated case, but I put this case here. You can search for your answer yourself because it is straightforward. Okay. I just want to know what kind of cases will you encounter. Okay. So for this patient, the father sustained severe burns. Okay, severe burns. And allergy to aspirin. Okay, remember you need to look into the allergy as well. So the status is unconscious, vital sign, BP is sky high. Okay, second and third degree burns of upper and lower extremities. Okay, 40%. Okay, all these are the. Okay, so from the examination, they will notice that he has 45% body surface area burn. Okay, they have all the. So how to calculate? Okay, you can get it from the notes just now. I will share this later. Then discuss the appropriate regimen. So you use your Parkland formula. Okay, you are being given the total body surface area burn. You know the weight. Okay, so you calculate and you write down the regimen. Okay, monitoring parameters. Okay, you can refer it back as well. So same for this. And I want everybody to read on these up-to-date articles about the management of the severely burned patients. It is very clear and it is in detail on how to manage severely burned patient. Okay, so this one. For these two articles, I will upload it on eLearn for you to read. This is extra reading. Good to understand burn and trauma. Okay, these are the additional self-reading and reference. They are not complicated, they are not long. So please read, Okay, so that's all. And another thing that mentioned in these up-to-date articles is beside the long-term management, beside the wound management, okay, long-term management for the wound, for the scar, we also need to take care of the post-traumatic syndrome of the patient experience. Normally, when they experience burn, they have just experienced a very traumatized situation. So we need to ensure it is well being taken care of. Okay, so that they can slowly come up from the traumatic experience and slowly go back to work. Okay, you read this up, it is very clear that it will be mentioned inside. Okay, so I hope you can hear me clearly because I keep coughing. So any questions? I know that someone asked about the case just now. Is it because I couldn't hear it? Maybe you can ask again. Okay, after this I will, yeah, come.
Just now the question was about regarding the sulfasalazine and diclofenac. If the question didn't specify why the patient is having stomach discomfort, so do we answer for both or do we assume it's due to sulfasalazine?
Okay, it cannot assume to be one because both drugs also, there's possibility that will cause GI discomfort. So you should mention both. Then perhaps the management part, you need to identify, or there is a way they should rule out what is the real cause of GI discomfort. Okay, so for GI discomfort, gastric. Okay, for gastric, normally it is NSAIDs. Okay, for sulfasalazine, normally it is nausea and vomiting. Okay, so this we need to differentiate between this. But if it is general GI discomfort, then it can be either one. Okay, so more investigation, monitoring, and more questions need to ask towards the patients for us to determine, okay, to identify what is the real reason that cause GI discomfort. Okay.
Thank you, Doctor.
Okay. After this, I will upload both notes, I mean the lecture notes and the 2 documents. Okay, for up to date, you can copy and paste the link and you can read it yourself. Okay, any other questions? For burn, it is important to know how to calculate the total body surface area and also how to apply Parkland formula. Okay, all good? Everybody still okay? All right. So if all good, then we will stop here. I'll see you back after this. Thank you very much, everyone.